transferred to emergency. They couldn't reach the doctor. And there was a crisis, transferred to emergency. Not good for the patients, not good for the nursing staff. Everybody was, the emergency was overloaded with these patients who really shouldn't have been there. So we designed a prototype. There was a visional medical director, regional director in our community said, you know, if you can imagine something better, build it. And we did. We assigned one person as a medical coordinator, and we had 9 residential facilities with 9 medical directors who had some overlap in different facilities. They were doing their thing, but they were doing it all independently. In total in our community, we had 860 funded residential beds. We had the $350 per bed, plus we allocated $50 for administration and meetings, so that gave us a budget of $400 per bed. We signed a service contract on March the 1st, 2011. So right off the bat, we signed a contract with 2 visionaries in residential care, Dr. Stephen Brown and Barbara Korabek, who's not here right now, but she was a visionary in guiding that process from the Health Authority. So from the Health Authority, and so from the ministry and the division, it was an early partnership. What were the benefits that we realized? We were able to form those networks that you're hearing about, that brought physicians together to provide best practices. We were able to hire an administrative assistant. We were able to provide 24/7 coverage with a single phone number for contact in the facilities, with pickup, you know, within 3 minutes. Most of our calls, 90% of our calls were picked up within 1 minute. We had regular educational meetings, including polypharmacy reduction, and we hired a pharmacist on contract to come to all our meetings and to instruct us on best uses of medications and polypharmacy reduction. She's been brilliant, and she's been a brilliant collaborator. We were able, as a group, to understand better the health trajectory of residential care patients, and we were able to institute appropriate end-of-life care measures earlier. And we were able to give better support to patients and families and colleagues, and increase the capacity to pick up the unattached patients. Is that enough? I mean, that's quite a bit. But in addition, there were 3 other things that we were able to achieve. We were able to mention new physicians and family practice residents into the program. And we recruited 4 new doctors, which is remarkable, because everybody says, well, you know, who's going to do this work? But if you have a coordinated group of people doing good work, other people are attracted to it. We were also able to contract our services as a group to cover the PATH unit and the private facilities. Under the new agreement, private facilities will be brought into the agreement, so all vulnerable, frail, elderly, and residential will be covered, not just people who are in the funded beds. And the last thing, good timing, we were able to track and evaluate our successes and shortcomings. We were able to aggressively get into the data and track it and measure how things were before we started the program and how they looked after the program. And then we can continue to evaluate it and compare all the sites and see what's working in one site and what's not working in another site, and what's working overall in the program. We're at the point now where, like this meeting, we're revisioning how can the program be better, how can we take it to the next level, and take our successes, build on the successes of other communities, and implement other things to make it stronger, like educational supports, which we talked about during the break meeting. We had a good group talking about educational supports. What can we create for educational supports for this program as it rolls out? The last thing, my time's up, is it fit with triple aim? Yes. The patients are happier, the providers are happier. Is it sustainable? We think it is. And we've also created a tool for geriatric prescribing, which is this tool here. It started as a flip chart, and it's we've made it into an app. It's a patient management tool, very simple. The nurses use it when they find a patient example, go through the causes of delirium. They can call the doctor with good information. The doctor can take it to the next level and come up with a care plan. So these kind of tools can deepen and expand the programs throughout the province. So, thanks. If you want to see the data or see the tool, I can demonstrate it very briefly.
Maybe what we'll do is we'll just open it up. And I think we might have mics to just pass around too, just so that everyone can hear. And anyone from the panel that wants to answer the question, feel free to take it on.
I'm not sure who to direct this to, so please, anyone. If you could comment on any experiences that you had where physicians who had a number of residents in a residential care facility were reticent to giving those up, and how did you deal with that?
I think that'll be a problem that we're going to face, just because physicians tend to have that nature, right? We don't want to give up our patients, and if we're going to have an impact on our community, if we're going to consider clustering our patients, so that it makes it easier for all of us to do the care that we need to provide, we're going to have to be able to share. That's, it's a fact. Yeah.
We're actually starting to look at that as well, because we have, I think, most of our physicians involved, like 50 plus physicians, and we want to still keep them involved, but what we're suggesting is, like, say for Penticton, we have 5 facilities, so if they pick one facility, we want to develop that team-based care. So it's not like they're saying, no to patients. They're just saying that they're going to be visiting more, they're going to be able to provide better care. And so we'll probably pilot it in a couple of facilities and demonstrate how that will work, and hopefully it will spread that way. We're also doing it as new patients come that are unattached. We then attach them in a cluster fashion.
The last thing is that physician autonomy will still be preserved. I think it's important to respect that. If physicians want to continue looking after the patients and doing a good job, they should be encouraged to do so. And patients and families should have a choice of picking who they want to look after them too. So that exists in this model.
In Prince George, we're blessed by a geography that allows access to all the nursing homes within 5 minutes of driving. And so the clustering question hasn't been a real big question. The question has always been, will you continue to look after your patients in residential care or not?
Yes, well, in Chilliwack, I think the choice was a big consideration there. But having a good conversation with some of the MRPs that had patients within the care facilities. Not every physician is comfortable or really wants to work within a residential care facility. And so when we started with the clustering, we felt it had some success in taking on some of those patients that were not necessarily being cared for even. But, we did learn for a fact that some patients wouldn't be being seen by their physician for even 1 or 2 years. So but having good communication back to the physician community is important.
I have a question for Murali. When you linked the after-hour care to the other day, was there much pushback from physicians who weren't necessarily on board with providing that after-hour emergent care to the facilities?
We fortunately did not have pushback. We haven't yet. Because we in Penticton, we have pretty well most of the Summerland Penticton physicians still have hospital privileges. We sort of brought it to the sort of physician meeting there, and it was more of a consensus base. So there were a few murmurs, but they quickly sort of acquiesced. We are going to be reevaluating how the Dr. Day and residential care is connected, and we are going to look at how do you keep it sustainable, because you don't just want a body, you want somebody that actually is willing to go to the facility, have the conversations with family that they don't know to try and avoid that transfer. So that's the PDSA part of, I think we're probably going to be looking at some changes to that.
So I'm curious about, once you had your system set up or your program set up, how much ongoing support does it need? Like, you know, out of your budget, how much did you budget for as far as, is there ongoing administrative costs and that sort of thing? And how did you monitor?
We actually were very fortunate because we applied for innovation funding, and that really helped us in terms of our quality improvement and evaluation. So we started out with a coordinator who worked quite closely with the 2 medical coordinators, and I think initially she was 15 hours a week, and actually we expanded that, and that really allowed us to work on like the communication tools, care conferencing protocol, and then even taking a look at like how do you know if our MRPs were actually going into the facilities, because we kind of wanted to know who was and if we're compensating them to do the work. And so every 6 months we would you know, find out how many are going in, and if not, we would have to go out and we could list from the physicians, and we'd say, oh, you haven't seen any patients. Well, then we would go out and work with or have a conversation with the physician to say, you know, what's happening? Is there something that's keeping you from going in there? Is there, you know, is this something that you want to do, something we can help you with? So it actually took some time, and that's why we really feel quality improvement, evaluation, that type of support and medical leadership is really important to move it forward so that you can make that cultural and practice change.
So the question you might want to ask is how much hassle and factor is this for the division workers to take on yet another project, and how much administration is involved, particularly with the cold shower of the attachment initiative just having been have most people up to their neck in as much as they need. This one was designed to be almost the polar opposite, if possible, for the division people. So clearly a meeting has to happen, or two. We would expect in most communities there's already kind of a keener or somebody who's interested in this sort of subject, physician leader. Maybe some communities are already replete with a scheme already, so if they apply for this incentive, they virtually have to do very little, because they might have a group and a call system and what have you. And then from the division's point of view, they would be where there is a division, or if there's no division in the community, there's, we call that, I forget the title, but it's most interested party or self-sustaining group or something like that. But from a place with a division, they would receive the funds, and that would be computed. We have a pretty good idea of how many beds there are in each area, and we would take that number and multiply it by 400 and divide it by 4, and that would be the quarterly amount of money that would be given to the division. And then we would have something called monitoring, and what we hope to be able to do is provide the information to the division. They don't have to do it themselves, from both MSP data and something that we would do centrally. So they would receive a quarterly report of how they're doing on the best practices. So their job at that would be to have, in one of the meetings they might have, to say, how are we doing compared to other areas? Are we meeting these expectations? The best we can figure out are people showing up when they're asked to come, when the patients go downhill in a hurry, and are we getting some drug reviews, and are we getting some documentation for end of life that wasn't there before? So I would say, based on some other requests of the division workers, this one is a bit on the light side, which I think would go over quite well in this room.
Question at the front and then at the back.
Is it working? Yeah, okay. I put my hand up earlier and I think you partly answered it. I think I'm the Comox Valley, and I think we get pretty good coverage from our physicians for our residential care patients. And I think the issue may be that the physicians want to hold on to their patients and they may not be provided those 5 levels of care that you talked about. And I was looking for tips on how you can encourage that. And you mentioned that maybe it has to come from gentle reminders. But has anything else worked?
Peer pressure.
I think one of the things that can really help improve that aspect is around the education component of physicians. So, and you know, there are probably a lot of physicians that don't do a lot of residential care or frail elderly support. So, having that kind of ongoing education is really important, and it gives them, you know, a level of support that they feel more comfortable with.
Care conferencing was a real interest to us, and it looked like a dog's breakfast at different facilities, right? And some of them, we were talking about whether someone went on a picnic instead of what they actually needed to talk about. And so they actually took a look at what was a care conference, making sure that everyone was on the same page, and then coming up with some care conference protocols, and also tackling the issue about scheduling care conferences so physicians can attend. So our increase, we've had an increase in physicians attending them because they're more meaningful, they know what the purpose is, and they can attend.
I think, you know, structuring kind of a plan toward achieving some goal that we've set out is really what works the best. And we notice in our division that coaching, you know, setting up helping people set goals together and coaching toward achievement of those goals is what works. And we've seen that in across primary care, and we've seen it a little bit in residential care because we've done a few structured things, like the polypharmacy initiative. And so doctors are all over giving the best care that they possibly can, particularly if everything is lined up for them to actually pay attention to the things they need to pay attention to. And so I think that we need to, and I don't think it's a huge investment, but some of these initiatives, I have to say, don't have that really built into them. And you know, I would say we have delivered an inpatient program for a long time, since 2009, and the residential care program since 2012. And you know, we're going forward. I don't actually believe they have enough administrative money in them. You know, the first year that we shifted over to delivering inpatient care to unassigned patients, particularly through the attachment initiative, we had got a little bit of money, actually an adequate amount of money for administration in that year, but it was only the first year, just the startup year. And so we need to continue to support the initiative, but we don't actually get that money anymore. And so every new program you take on that does not come with an adequate amount of administration funding just kind of picks away at you until you don't really do anything well anymore. So I want to say that I think we need to be cautious as we're rolling out the initiatives. I don't think it takes a lot, but I think we need to pay attention to it. So, you know, helping doctors achieve the goals that we're setting out here, because they do want to do the right thing, but it's not easy to do the right thing.
So Sue tells me we have about 3 minutes, and I know we have 2 questions. So there's a question back here, and then a question back here.
Okay, thanks. I'll be quick. I was just interested in the model that had physicians go in and do, it sounded like a little shift in the residential care facility. And I was just sort of curious how you managed the funding with that, because I'm assuming that physician who was there that Saturday afternoon, or however it worked, would they see everyone's patients that day, or did I misunderstand the model? And I just wondered if they were providing sessional funding for that day, or how that was managed.
We had this regularly, and it's actually set up on Chima, so 12 physicians would either sign up for a certain day or be asked to step in, or Lee would actually step in when there was a blank, when there was a space to be filled. And and they were given a stipend based on how much time they were there. And the nursing staff were asked to have their questions ready and be prepared for them when they came, so that when they came, they were organized, answered all the questions pertaining to the patients.
Maybe one last question in the back.
Yes, I was just wondering how you managed to bridge relationally with medical directors at all of the facilities. And having said that, has anybody thought about or used a hospitalist model in rolling this out?
We don't have medical directors.
Yeah, exactly.
Through the health
Medical
authority.
director, yeah.
Some might.
I didn't quite understand the question. You're asking about hospice doing the care or linking with hospice?
No, it's residential care. And just that at the facilities, there's medical directors.
Yeah.
Yeah, you don't have that.
We have medical directors in our community, and the medical directors do have hospital privileges, and they follow the course of the patient from facility to hospital, and then hospital back to the community or the residential facility. So we try to manage transitions in care. I think it's important to try to incorporate that. Some of them do come under the hospitalist program when they come to hospital, but we're talking about keeping them in the facility.
We have medical directors. Our problem is getting more medical directors rather than just one medical director doing all the sites. And it's trying to onboard people to do that.
Okay, so maybe I will wrap up because Sue's looking at us. What I would say is there's a one-page write-up about our initiative over on the far right for anyone that hasn't seen it, how to get started. There's an email contact as well as a phone number. Each of the 5 prototypes have written a short document, 3 or 4 pages, providing a bit of detail around their initiative. If you email me, I'm happy to send that out to you. It's also going to be up on the DivIT site shortly. So with that, I'd like to thank our... Sure, and in each of the